So let's start with obstructive coronary artery disease, what we really see on a day-to-day basis. It's still the most common manifestation of ischemic heart disease. It's accounting to 60 to 70% of what we find on the angiogram. And it's a big population burden, right? 18 million patients with coronary artery disease, 2/3 of them with some sort of symptomatic disease involving obstructive epicardial disease. On this global level, how can we differentiate what's truly ischemic heart disease from what's non-ischemic chest pain? What do you do in your clinical practice? How has that evolved over time?
That's really sort of been the real big evolution in our field. So classically, treadmill stress testing, stress echocardiography, SPECT scans were the mainstay of outpatient evaluation of these patients. That's honestly become far less of our clinical practice currently. We do a lot more PET scanning, stress MRI. We find that these tests are a lot more objective in terms of avoiding some of the pitfalls of artifacts and false positive results, false negative results. But that's evolved. And honestly, it doesn't necessarily apply to the vast majority of patients because access to these types of tests are not readily available throughout the country and throughout the world. So this is an ongoing issue.
So let's shift to the other population, which is sort of newer on the block, and that's this angina with the non-obstructive coronary disease. So maybe not someone that you see so much, but a lot of hospitals now have these chest pain clinics, and they're doing investigations for microvascular disease, coronary spasm. How much of a burden do you think this really is, and how do you find and treat these patients differently to the patients where you're such an expert at treating obstructive coronary disease?
I think that that's still something that we're starting to understand a little bit better. And quite honestly, my impression is this may just be the tip of the iceberg in terms of the types of patients that we're leaving untreated. Because as I understand it, nearly half the patients who are referred for an invasive angiogram for evaluation of chest pain end up not having significant epicardial coronary disease. So this is a huge, huge subset of the patients that are referred for an invasive evaluation of chest pain. And yet we don't currently have particularly fantastic treatment options. Obviously, medical therapy is what we can offer, but it just doesn't seem to address the majority of our patients. They keep coming back with recurrent symptoms to the ED and get admitted to the hospital, have multiple invasive procedures done with the same results, no significant flow-limiting epicardial coronary disease. And what do you do with these patients? It's a huge, huge challenge.
So let's move a little bit on from there and talk about how you're currently treating obstructive coronary disease in the outpatient clinic. So your patient comes in, they've got angina, you think it's legitimate, you're picking your test of choice, whether it's CT or PET or MRI. Tell me about modern day medical therapy and the impact of that on your practice.
I think that being involved in the clinical trials that we're involved in for management of patients with refractory angina have honestly made us much better at the medical management of these patients because most of these protocols mandate maximizing patients on at least 3, if not all 4 classes of anti-anginal therapies or documenting intolerance to the drugs before we can enroll them in trials. So that's honestly helped us be much more cognizant of opportunities to help our patients. So maximizing beta blockers, calcium channel blockers, oral nitrates, ranolazine. These things do help patients. Not all patients can tolerate these things, and they're not effective in all patients, but to not offer these up front and go straight to an invasive strategy, I don't think it's necessarily fair, and it's not necessarily giving the patient every opportunity to get better.
A lot of people have analogized this to sort of people with knee pain who need a joint replacement. You've heard this before. They're like, well, you're struggling along with a cane now because your knee's hurting so much and you're taking, 2,400 milligrams of ibuprofen every day. Obviously, all those drugs have side effects and people are able to go and see the orthopedic surgeon to get scheduled for knee surgery. Do you think that's a valid analogy for coronary artery disease, or do you think that medical therapy doesn't have the same, A, potential side effects, and B, should be mandated before revascularization?
I think that's a great question. And I would tell you that every patient is different. There are patients that simply cannot tolerate even a negligible dose of beta blocker without some intolerance. And there are patients that are on 200 BID and they're doing just fine. So I don't know that I necessarily know how to answer that other than I feel that if before I want to subject a patient to the risks of an invasive treatment strategy, I want to at least have explored this in a responsible way with the patient to make sure that we haven't missed an opportunity.
It's amazing. Just as I asked you that question, I was thinking back into my own practice and thinking how much of any outpatient clinic appointment for a patient with angina or for a patient who's being revascularized is me trying to parse out what side effects they're having from the drugs. I mean, you've got worsening kidney function, you've got erectile dysfunction, you've got shortness of breath with the antiplatelet drugs, you've got muscle aches from the statins. The medical therapy arm is clearly very efficacious and valuable, but it's not without its costs. And so, like you said, I really appreciate and echo the fact that every patient is different. And there's going to be some patients who need a knee replacement who just want to have it right away because they, want to get back to their life. There's others going to say, well, mine's not so bad. I'm okay with taking some acetaminophen every few days and managing. So I completely understand that and echo with you your thoughts.
The other way of thinking about this is patients have varying expectations of what's lifestyle limiting. So, right, I've got patients that feel perfectly fine, but insist on being able to mountain bike at 3,000 feet, right? So that's the only time they experience angina when they're in their vacation home. But that's their symptoms that are lifestyle limiting, right? And then there are patients who have angina getting from the waiting room to the exam room. Everybody's different in terms of what they expect and what they want. And so our treatment has to be tailored accordingly with everybody understanding the risks and benefits of all these options.